We can start with our lesson. Each layer of the heart can be involved in patients affected by rheumatic disease, and in particular pericardium with pericarditis. It could be involved in patients with rheumatoid arthritis, lupus, and many other diseases. Also myocardium with myocarditis, and in particular with systolic dysfunction in patients affected by lupus, rheumatoid arthritis, and systemic sclerosis prevalently. Endocardium can be involved in patients affected by this disease, and in particular we can find Libban-Sachs. Libban-Sachs is a valve involvement in those patients that there are the positivity of antiphospholipids. Also, the conduction system can be involved with atrioventricular block, arrhythmias, prevalently in neonatal lupus, babies born from mother with the positivity of anti-RHEO-SSA. Coronary arteries can be involved with the accelerated atherosclerosis in patients with rheumatic disease. Not only, but also pulmonary circulation can be involved with the hypertension prevalent in patients affected by systemic sclerosis and antiphospholipid syndrome. About the pathogenesis, the heart involvement is characterized particularly in those patients with the positivity of autoantibody. So, in lupus and in antiphospholipid syndrome with the positivity of anti-dsDNA and antiphospholipid antibodies. Also, the inflammation can be involved in patients with heart disease, in patients affected by rheumatic disease with the complement activation. Most commonly affected is the mitral valve. Atherosclerosis is the pathognomonic prevalence in patients affected by systemic inflammation and also in patients with heart involvement, with high level of TNF-alpha, IL-6, IL-1, CRP, oxidative stress, dyslipidemia can be present, corticosteroid use in these patients with hypertension, high level glucose and overweight, and also for the prothrombinic state. These are responsible of coronary artery disease. Now I introduce Elisabetta Zanatta, where is there? She continues with more specific detail in connective tissue.
Thank you, Professor Ramonda, and good afternoon, everyone. When we speak about heart and rheumatic disease, we mainly refer to autoimmune rheumatic diseases, particularly connective tissue diseases, inflammatory arthropathies, and this will be the focus of our talk, and systemic vasculitis. These conditions are characterized by inflammation and fibrosis with varying degrees depending on the disease itself and the phase of the disease, of course. Among connective tissue disease, heart disease is most relevant in lupus, systemic lupus erythematosus, and you know that this autoimmune disorder is characterized by the presence of autoantibodies. Typical are those against double-stranded DNA, and SLE commonly affects young women, as you can see on the left. The clinical involvement is very heterogeneous, and the cardiopulmonary involvement can be detected in about 1/3 of patients. As you can see in this review on acute myocarditis, lupus is one of the most frequent etiologies among autoimmune rheumatic diseases, can present with myocarditis up to 10% of patients. They are usually males, young males, because keep in mind that although in connective tissue diseases the male sex is less frequent, normally these patients, male patients, have a more severe disease phenotype. This is typical among patients with connective tissue disorders. Compared to historical cohorts, more recent study found a lower prevalence of myocarditis, and probably this is due to the increased use of biologic therapy, immunosuppressants in rheumatology. And indeed, as you can see from this French study, myocarditis is a typical manifestation that is associated with other signs of lupus disease activity, both serological and clinical. The clinical presentation is highly variable, from asymptomatic patients to palpitations only to initial heart failure, up to the most severe manifestation, which is cardiogenic shock. And you probably know that among patients with cardiogenic shock, lupus is the most frequent rheumatic diagnosis. So it is also well reported in the literature that among patients with acute myocarditis presented with cardiogenic shock, lupus, this may be the first manifestation of the disease, so leading to the diagnosis of lupus itself. And among other clinical features, this study found that the prevalent and incident myocarditis in lupus patients is strongly associated with the presence of antiphospholipid antibodies. It is very important to consider when we speak of heart involvement and lupus that a potential cardiotoxic drug, that is hydroxychloroquine, is the first line treatment, as you can see here, for all the forms of lupus, so mild, moderate, and severe. And this is very important because we need to take this into consideration. And the clinical presentation of iatrogenic damage from antimalarians may be very similar to that of myocarditis, because we can have heart failure with the preserved ejection fraction, syncope, and other manifestations typical also of myocarditis. It is very important to also consider the duration of the treatment, because the risk typically increases after 10 years of treatment with hydroxychloroquine. And normally patients are not patients with a great lupus disease activity. You need to know that biopsy, endomyocardial biopsy, is the only test really able to perform the diagnosis. But we have other involvement typical of SLE. Pericarditis is even more frequent in these patients, about 30% of patients. And even in this case, this is a typical manifestation during an active phase of the disease, the so-called flare of the disease. And it is normally associated with pleurisy. That is another very frequent manifestation of these patients. Just like myocarditis, the pathogenesis is linked to the depositions of immune complexes with complement activation and systemic inflammation. Another important point is that valvular disease is more frequent in SLE patients than in the general population, in particular with a prevalence of 20–30% of mitral valve thickening and regurgitation and aortic valve thickening. We need also to remember, as we previously mentioned, that these patients may also have Lehmann-Sachs endocarditis that is considered sterile forms of endocarditis that is typically associated with the presence of antiphospholipid antibodies and mainly affects the mitral and aortic valve. But we also mentioned the increased cardiovascular risk that is typical of our patients, that is mediated by inflammation. And as you can see, for example, in SLE, we have a remarkable increased risk of myocardial infarction among young people. That is a typical feature of SLE patients. We know that the primum target is the endothelium with the increased recruitment of inflammatory cells, increased foam cells production. We have the muscle cells migration, and we have that autoantibodies and cytokines accelerate the process of unstable atherosclerotic plaque formation that, as you well know, is the typical substrate of the myocardial infarction. As you can see from this slide, we have several core studies demonstrated that SLE and rheumatoid arthritis patients have an increased prevalence of atherosclerotic plaques compared to controls. And we need also to mention neonatal lupus. Neonatal lupus is not a complication of lupus patients only because it is caused by the presence of anti-SSA and anti-SSB antibodies. And there is the transport via the placental transport to the fetus, and with several clinical manifestations. The most frequent and the most severe is the heart block of the fetal heart block. As you can see, these antibodies are not found only in lupus patients, but actually in every type of connective tissue diseases. And this study demonstrated that hydroxychloroquine is able to prevent recurrent heart block in women with this autoantibody positivity. But we have another connective tissue disease with high frequency heart involvement, and this is systemic sclerosis. Systemic sclerosis is characterized by a diffuse microangiopathy and immune activation that led to fibrosis. Fibrosis is the hallmark of systemic sclerosis. And also in this case, as you can see in this picture, the clinical manifestations are very heterogeneous. Due to its etiology, we have that myocardial involvement in scleroderma is mainly due to a fibrotic process with patchy fibrosis that is secondary to the so-called Raynaud's phenomenon of the heart, and this is the most frequent involvement in this patient, while a real immune-mediated myocarditis is detectable but is less frequently reported. There are several evidence that the origin of cardiac involvement in scleroderma is microvascular, and also autoptical study contributed to demonstrate that we have an ischemic necrosis, reperfusion injury due to the so-called Raynaud's phenomenon of the heart with microvascular damage. This led to fibrosis, and when fibrosis is diffuse, we can have a restrictive cardiomyopathy with the typical picture of diastolic dysfunction that is more common than systolic dysfunction in scleroderma patient, and is a well-known poor prognostic factor. As you can see, we also contributed to strengthen this concept, demonstrated that there is a clear association between microangiopathy, the NAFLD microangiopathy, and coronary microvascular dysfunction. So the disease is systemic. And the biopsies from these patients highlighted the high frequency of fibrosis that is higher compared for frequency and distribution and diffusion compared to other forms of virus negative myocarditis. And this fibrosis is also strictly correlated with skin fibrosis, with can measure skin fibrosis via the modified Rodnan skin score, and there is a greater arrhythmic burden that is which is probably responsible for the increase, the occurrence of sudden death that is reported in scleroderma, and we can see also in clinical practice. Okay. Considering the pericardium, in this case, a real inflammatory pericarditis is very rare. Unlike the presence of asymptomatic chronic pericardial effusion that is common in these patients. And we need also to mention, mainly considering the right heart, pulmonary arterial hypertension, because as you can see, about 10% of scleroderma patients have this complication. This is a vasculopathy of pulmonary artery, small pulmonary artery, with right heart failure. And this is a complication of the disease with a very poor prognosis, as you can see in this slide. Finally, idiopathic inflammatory myopathies. They are an heterogeneous group of diseases with inflammation in the muscle. And as you can see, we have 6 types of inflammatory myopathies. And even the clinical diagnosis of myocardial involvement is quite rare in these patients. In autoptical study, myocarditis, signs of myocarditis and focal fibrosis were the most common features. And among all the types of idiopathic inflammatory myopathies, anti-tRNA synthetase syndrome is the most most frequently involved when we speak of heart involvement, particularly patients with anti-Jo1 and anti-PL12 antibodies. Also, in these cases, normally the myocardial involvement is associated with active myocarditis and also with other features of active disease. For example, the presence of fever, that is another feature typically found in this syndrome. I remember you that in this syndrome, compared to the other forms of myositis, we have a high frequency of Raynaud's phenomenon, and this is a link with scleroderma and the pathogenesis of the cardiac involvement, and also increased CRP. For inflammatory arthropathies, okay.
Also, in arthritis, it's possible to find the heart involvement, and in particular, we know that arthritis is frequently associated with many extra-articular manifestations, as you can see in this slide, the heart, the gut, and so on. Rheumatoid arthritis, as we know, is a chronic inflammatory disease. It is characterized by the involvement of the mobile joints, and it is characterized by the inflammatory process that it is an erosive process with the evolution to bone destruction and ankylosis and deformity of the joints. Pericarditis is quite frequent in patients affected by rheumatoid arthritis. In fact, the cardiovascular manifestation is between 20 and 50% of the patient. It is prevalently asymptomatic and only clinical evident in 5 to 10% of the cases. These cases are prevalent male with nodular active seropositive arthritis, so rheumatoid factor positive and anti-CCP positive, with real aggressive form. Pericarditis is frequent in patients affected by pericarditis. In the rheumatoid arthritis, we can find a high level of TNF-alpha, IL-1, IL-6, a real inflammatory process. Pericardial fluid is characterized by the presence of the immunocomplexes, positivity of rheumatoid factors, neutrophil, high level of inflammatory protein, low glucose, and low complement. The prognosis may be severe in those patients that pericarditis is constrictive with calcification and sometimes with cardiac tamponade. There are some cases of possible TNF-induced pericarditis in the context of drug-induced lupus or vasculitis in patients treated with rheumatoid arthritis. Myocarditis is rare, but is possible to find frequently in asymptomatic patient, between 3 and 30% of a patient. The histopathological aspects are characterized by focal lymphocytic, diffuse necrotizing, or granulomatosis myocarditis. In those patients where we found also the subcutaneous nodule with the positivity of rheumatoid factors. A meta-analysis that show that the presence of cardiovascular risk in patients with rheumatoid arthritis underline that the increased risk is in patients with rheumatoid arthritis and cardiovascular disease compared to the general population, but in particular in those patients with high disease activity. About spondyloarthritis, another group of the disease is a group of related disorders characterized by clinical, radiographic, and genetic features common. Rheumatic disorder is characterized by the presence of synovitis and enthesitis, and extra-articular manifestations are characterized by uveitis, inflammatory bowel disease, sometimes extra-articular manifestation, the comorbidities such as cardiovascular disease, hypertension, and obesity. In this slide, you can see the typical manifestation, clinical manifestation in patients affected by spondyloarthritis, and there is a genetic predisposition common in this disease, characterized by the positivity of HLA-B27. In spondyloarthritis, the involvement of heart is characterized, and we described in these cases patients affected by ankylosing spondylitis that developed hypertension, peripheral edema, renal insufficient, and she was developing in really insufficient renal insufficiency and required the kidney transplantation. Not only, but she developed also severe sclerotic aortic stenosis, requiring also percutaneous aortic valve replacement. In fact, in spondyloarthritis, it could be associated with increased prevalence of valvular heart disease, and in particular aortic insufficiency and aortic stenosis, less mitral stenosis and mitral insufficiency. About the treatment, when we treat this patient, we can consider the disease, the rheumatic disease, and so it's important to treat this patient with glucocorticoid and immunosuppressant, in particular conventional synthetic DMARDs or now biological drugs, but it is also important to treat the pericarditis, the involvement of the heart with NSAIDs and colchicine. It's really important to control cardiovascular risk factors, in particular with the statins and so on, and also preserve the pulmonary function with vasodilatators, and obviously neurohormonal therapy in this patient. Thank you very much for your attention.